I'm really thrilled to be able to introduce today's first speaker, Dr. Robert Carlson, and we're really fortunate to have him join us this morning. Dr. Carlson is the CEO of the National Comprehensive Cancer Network, Professor of Medicine Emeritus at Stanford University Medical Center, Adjunct Professor of Medical Oncology at Fox Chase Cancer Center, and a practicing board-certified medical oncologist. He served as founding chair of the NCCN Guidelines Panel for Breast Cancer, the NCCN Guidelines Panel for Breast Cancer Risk Reduction, and the NCCN Guidelines Panel for Survivorship. Dr. Carlson will share how NCCN guidelines are used for worldwide cancer care and how patients can utilize the patient guidelines as a tool to participate in shared treatment decision-making. Dr. Carlson?
Thank you, Beth and Kelly. It's a real pleasure and an honor to be with you today to talk about some resources that are near and dear to my heart. The National Comprehensive Cancer Network has two major sources of resource that would be important to you all. One is the NCCN Guidelines, and the other is the NCCN Guidelines for Patients. If you're a patient with cancer in the United States, in the vast majority of circumstances, your care has actually been impacted either directly or indirectly by these resources. Am I sharing the screen or are you sharing the screen?
Nope, I'm going to put that up right now, Dr. Carlson.
Okay.
Just wanted to wait for your go ahead.
Please do.
1 second. Okay.
So as those are coming up, the NCCN is a not-for-profit alliance of 30 academic cancer centers in the U.S. And relative or important to those of us in the Philadelphia area, there are 4 institutions relatively close by that are members of NCCN. The Fox Chase Cancer Center here in Philadelphia, the Abramson Cancer Center at the University of Pennsylvania, and close by in the region, Johns Hopkins Kimmel Cancer Center is also a member institution, as is Memorial Sloan Kettering Cancer Center in New York. Okay. So, request remote control. Okay, here we go. So as a not-for-profit organization, the NCCN is strictly mission-driven, and our mission is to improve and facilitate a quality, effective, efficient, and accessible cancer care so that patients can live better lives. So this slide shows the number of publications that are indexed in a database called PubMed that is maintained by the U.S. National Library of Medicine. And what they do is if a scientific paper is published in high quality journals, they add that publication to this database. And what this slide shows in blue is the number of publications indexed in PubMed by individual calendar year, representative years, relative to breast cancer alone. And as you can see, in 2019, there were over 14,000 articles published and indexed in PubMed relating to breast cancer. And if you look only at clinical trials, those studies that would be most important for application of therapy in the clinic, there were still over 1,100 trials reported. This would mean that if you were a breast cancer specialist or treating people with breast cancer and you were trying to stay abreast of the literature, you would have to read over 40 publications per day throughout the year to stay current. And if you were going to focus only on clinical trials, you'd still be reading about 3 clinical trial reports a day. Now realize that the usual medical oncologist in community practice sees multiple different cancer types per day. They may see 5 or 6 different cancer types in their clinic. And what this means is it's virtually impossible for a busy practicing clinician to stay current with the world's literature relating to oncology. So how can we work to solve that problem? Well, one of the ways is through what are called clinical practice guidelines. And the Institute of Medicine 30 years ago defined a clinical practice guideline as systemically developed statements to assist practitioner and patient decisions about appropriate healthcare for specific clinical circumstances. Important to note, assist practitioner and patient decisions about appropriate healthcare. So the NCCN has a library of these clinical practice guidelines specifically focused on oncology. And there are a number of features of that separate our clinical practice guidelines from most other clinical practice guidelines. First of all, they're developed by representatives from multiple medical specialties. So we have on our guideline panels surgeons, radiation oncologists, medical oncologists, pathologists, diagnostic radiologists. Some of them have clergy, some of them have social workers, psychologists, pain specialists, and so on. It's a multidisciplinary group of individuals that develop this content. Our guidelines go across the continuum of care. So they start with guidelines on risk assessment, screening, diagnosis, treatment, surveillance, survivorship, and if necessary, end-of-life care. And there is no decision across that spectrum of treatment within the oncology diseases that we have guidelines for where there is not a recommendation in terms of what should be done. Our guidelines are unique in that they are literally updated continuously. They're living, dynamic documents that are updated on a continuous basis. Our panels are populated by domain experts within oncology and a specific disease or issue being addressed. And that's important because in many situations in oncology care, there is not high-level evidence that can help inform the decision-making. In fact, it's estimated that about 60% of the decisions that a hematologist oncologist makes every day in the clinic are not based upon a high-level scientific evidence. We can fill in the gaps where there is not that high-level evidence by our experts and their experience empirically. Our guidelines are also transparent. We tell you who develops our guidelines. We tell you how we develop our guidelines. And as I'll describe in a minute, we also inform you about what their potential conflicts of interest might be. Our guidelines also are very transparent in that we have 3 different systems that help explain the confidence that the experts on the panel have that the recommendation is reasonable. The first is what we call our categories of evidence and consensus. This tells you whether or not the recommendation is based upon high-level evidence, very convincing scientific evidence, or less convincing scientific evidence, and how many people on the panel felt that the recommendation was appropriate. We also have what we call our categories of preference, and they tell you if there are multiple different options, which option or options the people on the panel feel should be used in preference. And then finally, we have our evidence blocks, which are a graphical representation of 5 different issues relating to the recommendations. The first is how effective is the specific therapy. The second is how safe is the therapy. The third is how good is the evidence? What's the quality of the evidence supporting that recommendation? The fourth is what is the consistency of the evidence? There are situations in medicine where you have really great data, very convincing studies that show opposite outcomes or opposite results. And that's important to know. If all the major studies show the same finding, that's very helpful. But if they're contradictory, then you have to acknowledge that. And then the fifth dimension of the evidence blocks is that of affordability. How much is the delivery of that therapy likely to cost the system to be able to deliver it? And our guidelines are always supported by references and a formal manuscript so that the user of the guideline can actually look at what's the evidence that the panel considered in making those recommendations. There we go. Sorry, I'm having a little bit of difficulty advancing the slides, but we're getting there. why would we spend all this time and effort to develop these guidelines? First of all, the evidence that is utilized to develop the guidelines and the recommendations from that evidence are made by experts. We have 30 member institutions across the country, and if you look at the people that are on those panels, it's a who's who of that specific disease or that specific supportive care. We use an objective, consensus-driven, transparent decision-making process. We address the clinical decision points throughout the continuum of care, and we have guidelines that cover over 97% of all cancers that occur in the United States. We maintain real-time updates of our guidelines. Again, they're living documents to maintain relevancy and to ensure patient access. And ensuring patient access is really important because over 85% of covered lives by insurance in the United States are covered by insurance companies that use the NCCN guidelines in making coverage determinations in oncology care. We do not want a patient to be denied an effective and appropriate care because our guidelines are out of date. Consequently, there was a new lung cancer drug, for instance, approved by the FDA last Friday. Our staff is already working on having a panel meeting to review that recommendation and that new drug to see if it should go on our guidelines. And I can tell you that within 2 weeks of the approval, so 2 weeks from last Friday, our guideline will be changed if the panel feels that the FDA made the appropriate decision. Our guidelines are used as a basis for assessment of needs by health ministries and policymakers in the United States and health ministries in other parts of the world. They look at our guidelines to see if they add another resource in their healthcare system, what's the impact likely to be in improvement of healthcare. The use of guidelines minimizes variation in care, and we all do best what we do all the time. And consequently, if you minimize variation in care, your outcomes almost always improve. The use of guidelines also helps to avoid undertreatment of a specific cancer. It also helps avoid unnecessary treatment or overtreatment of a cancer as well. The guidelines can be used as a gold standard or a benchmark for assessing the quality of care and for developing cancer treatment improvement strategies. And then finally, the documents themselves are incredibly powerful educational instruments for both physicians in training as well as for continuing education for highly experienced clinicians. So if we look at the NCCN Library of Professional Guidelines, we currently have 76 guidelines that apply to, again, over 97% of all cancer cases in the United States. These 76 guidelines are developed by 60 different NCCN guideline panels that in combination have over 1,500 expert panel members. And we at NCCN, and we're headquartered right in the area, we're headquartered in Plymouth Meeting. We have 43 full-time NCCN staff members who are devoted specifically to our clinical information operations that develop the NCCN guidelines and the associated products. So how do we actually go about developing these guidelines? Well, the first thing we do is we gather all of the scientific information that we can from as many different sources as we can. The draft guideline goes to each of our member institutions for expert review there, for their comment on how the guideline should be modified in its next version. We have scientists that go through a clinical data review, PubMed literature review to identify studies of importance that have been published since the panel last met. We accept third-party submissions. Each and every one of you can go to our website and you can make a request to any of the guideline panels for a change in what the guideline states. And patient advocacy organizations and individual patients' input has been important in that process before. For instance, we developed a guideline for breast cancer treatment during pregnancy and one for inflammatory breast cancer specifically based upon advocacy input. The pharmaceutical industry can also make requests for changes in the guidelines. And this is the only way in which the pharmaceutical industry can actually communicate directly with our guideline panels. All the third-party submissions are published publicly on our website, so you can see what they are, and the panel determinations of response to those submissions is also published publicly. We review scientific congresses and presentations, and we do track new drug requests and approvals through the Food and Drug Administration for inclusion. Once we have all that information, we then develop a formal agenda. The panel meets either in person or these days by way of Zoom to review the new data and to discuss and dissect the quality of the data, what the studies really show, incredibly high-level discussions of the data, and then a decision is made whether or not to modify the guideline in response. Our staff takes that information from that meeting, develops the algorithms, and I'll show you some in a minute, develops the manuscript, add references, and so on to that document. That document then goes to the panel chair, vice chair, and ultimately the full panel for the review. And once they approve it, it's then published publicly on our website. And as soon as that happens, the long loop happens, the process starts again. Now, we also have what we call our short loop, and that is that the long loop happens at least on an annual basis. The short loop happens anytime a major study is published or reported that would change practice, or the FDA approves a new drug. Then we will have a short panel meeting that will focus specifically on that issue to update our guideline. So our lung cancer guideline currently is in its 6th version for 2020. And that's because there was one major annual review, which was version 1. And then there have been this sort of short loop updates to the guideline in the interval. Now, NCCN takes very seriously the importance of maintaining integrity to our guidelines. We want to shield our guidelines process from inappropriate external influences. And we do that in a number of ways. First is in terms of our financial support policies. 100% of the funding that is utilized to do anything at headquarters that impacts the content of a NCCN guideline is funded by dues from our member institutions. 100%. Not a penny of industry funds, not a penny of advocacy organization funds, not a penny of anyone else's dollars and cents gets into that pot of money other than our member institution dues. In terms of panel participation, the panel meetings are closed meetings. Only people on the panels and NCCN staff are allowed to participate in those meetings, and they are not allowed to communicate any of the information in those panel meetings externally until the formal guideline is publicly published on our website. And that's because the Securities and Exchange Commission doesn't like it when we release information early, which we don't. They wouldn't like it because our guidelines are so influential within oncology that actually an approval or taking a drug off of our guideline can move the stock market. And so the SEC does get involved looking at concerns of insider trading if there were a leak or a communication in advance of the public posting. We also have a very formal policy for guidelines disclosure. And what that means is that each and every one of the people in the room when a guideline is discussed or modified is required to provide both a written and a verbal disclosure of financial conflicts of interest. So this includes things like honoraria, consulting fees, stock ownership, salary, and it extends not just to the panel member, but to the panel member's spouse, domestic partner, dependent children, or any other dependent. And if the dollar amount of those conflicts of interest exceeds certain thresholds within the organization that are published, the individuals are disqualified from any panel participation. And then we also have firewalls internally at NCCN so that if someone in our business development group, for instance, has an interaction with someone from industry, where the person from industry says, I really think it would be nice if your guideline said this. Our business people are not allowed to walk down the hall and talk to our guideline people and say, I was just told that they would really like it, this one on the guideline. Absolutely prohibited. So again, we don't accept any industry or external financial support for the development program. The development is supported exclusively by our member institution dues. So do people utilize our guidelines? You bet they do. This figure outlines the annual number, the number of guidelines downloaded on an annual basis from 2006 to 2019. So in 2019, there were over 11 million copies of our guidelines that were downloaded either from our website or onto our mobile application. There are multiple other distribution channels for our guidelines, but these are the easiest ones for us to actually track. This makes them the most widely utilized guidelines in the world, at least in the field of medicine. If we look at the number of people who actually access our website, we have over 1.3 million registered users on our website. And of interest, about half of those registered users come from outside the United States. That's demonstrated here. That shows a heat map of where our guidelines are actually downloaded around the world. And the darker the color, the more guidelines are actually downloaded into that country. We have over 180 countries in which our guidelines are downloaded. And if you actually correct for population density and for the number of healthcare providers, oncologists especially, within these different countries, the distribution of our guidelines across the globe would probably be very similar across all countries. So do the guidelines make a difference? Great question, and it's been studied across multiple different trials. And what this slide shows is it shows the guideline being studied on the left. The disease of interest, or CINV, is chemotherapy-induced nausea and vomiting. The outcome that the study looked at and what it found, and then the reference in the literature. And as you can see across multiple different guidelines, but usually the NCCN guidelines, across multiple different disease settings, the outcomes were consistently positive. So decreased local regional recurrence, improved relapse-free survival and overall survival, decreased cost, improved survival, decreased nausea and vomiting, improved disease-free survival, improved survival, improved survival, improved survival, and so forth. And so the studies very consistently demonstrate improvement in outcome if the therapy that is delivered is concordant with guidelines, and again, typically the NCCN guidelines. This slide shows guidelines that have been, studies that have looked at guideline concordance and use more recently. They are all NCCN guidelines. I have not excluded any studies that I'm aware of during this time period. But again, you can see up to 2020, there's improvement in survival across multiple different tumor types. Importantly, also is the esophageal cancer study here, the fourth one down, where there was improvement in equity. Equity, of course, is a major focus of our country today, appropriately. And this study in esophageal cancer found that the disadvantage in terms of outcomes that was conferred by lower socioeconomic status went away if the therapy delivered to the individual was NCCN guideline concordant. So concordance with the NCCN guidelines is one way that we can stimulate or improve equity of cancer care in the United States. The next study down also showed decreasing costs, and specifically they looked at patient out-of-pocket costs, not just the insurance company costs, but patient out-of-pocket costs, and found that guideline concordance was associated with less expensive overall care. This slide shows the major outcomes of a study done by United Healthcare, NCCN, and a company called Evacor. United Healthcare, which is the largest private insurer in the United States, in 2008 initiated a policy that if a cancer chemotherapy or other systemic therapy was on the NCCN guidelines, they would pay for it. And despite that sort of broad inclusion, and it being very clear where physicians or healthcare providers could go to decide what therapy should be delivered, a number of patients were treated with therapies that were not on our guidelines, and United Healthcare therefore did not pay for. What they did, or we did, was we developed a computer-based decision support system where the oncology provider could go to this system and put in a brief amount of information about the specific patient and their circumstance, and then could say what therapy they were planning on giving. And that system would then say, great, it's on the NCCN guidelines, you have authorization to proceed with that therapy. Or if it wasn't on the NCCN guidelines, it would say, we can't approve that now. This is a list of therapies in this circumstance that we could approve because they're on the NCCN guidelines. Or if you're not happy with that, then you need to call us and we'll negotiate. So what was found was that the number of retrospective disapprovals of the therapy that was administered went from 4% down to 1%. And remarkably, and much to everyone's surprise, the cost of care went down. The cost of care went down big. The cost of care went down by 10% in Florida, which is where this pilot was done, while the cost of the same care in other places in the United States went up by 10%. So it was a 20% relative reduction in the cost of drugs in this circumstance by concordance with the guidelines. So providing optimal care not only improves outcomes, it's less expensive. And that's somewhat counterintuitive, but it is true. And there are others that are in the process of replicating this study, and we're confident that in fact they will be able to do so. So this slide shows you an example of an NCCN guideline. This is a page from the non-small cell lung cancer guideline, and it looks at patients with either local regional recurrence or symptomatic local disease, or with distant metastasis. And as you can see, it's complicated. It's very complicated. And this actually is just a very high level review and doesn't get into the details of the specific treatment. It's also written in language that doctors and nurses think in. Endobronchial obstruction, superior vena cava, hemoptysis, brachytherapy, and so forth. It's really high level technical language that's not particularly helpful to patients. With this guideline, if you go to the far right, you'll see that in most of the circumstances, you get to a point where it then refers you to systemic therapy, NSCL 18, which is another page in the guideline. And that's shown here. This again, incredibly complicated, incredibly technical. Unless you're a lung cancer specialist, the information on this page is incredibly difficult, even for an oncologist to be able to digest. But this outlines optimal treatment for non-small cell lung cancer in this circumstance. So with this degree of complication, how in the world can a patient and their family understand the therapy? And more importantly, how can the patient and their family actually participate in the decision-making for what therapies are going to be used and where and so forth? So NCCN, to help solve that problem, has developed a library of patient guidelines. Now, what these patient guidelines do is they take the professional guidelines and they take the information that you need to know, not the information that's sort of nice to know, but the information you really need to know to understand your treatment and the options of treatment that are available. The patient guidelines are translated, if you will, from the professional guidelines. We currently have 47 guidelines for patients that are currently available. And they're focused on cancer treatment, screening, supportive care recommendations. And of these guidelines, we also have 22 translations into non-English English languages. These patient guidelines, as our professional guidelines, are available on our website free of charge. You just go to our website. If you go to the professional guidelines to have access to them, there's no charge again. You do have to register. You have to register, but no dollars exchange hands. And on a patient website, you can access the patient guidelines without registering at all. You just go to the website and access the information. And again, they're available free of charge. Last year, there were about 900,000 unique visitors to our patient guideline site. We also have print versions of the guidelines if people prefer a print version that are available via Amazon.com, and we'll come back to that in just a minute. And we regularly survey the users of our patient guidelines, and we get consistently stellar reviews. This shows the number of patient guidelines that NCCN has had available and the number of patients with cancer in the US that are covered by these guidelines. As you can see, by the end of 2020, we expect to have 51 patient guidelines available for access, and that will cover over 95% of all patients with cancer in the United States. So for most patients out there, they have access to an NCCN patient guideline to facilitate their care. This shows the specific cancer types that we have patient guidelines for. As you can see, it's quite an extensive list. We also have patient guidelines for non-tumor specific therapies. So these include some of the issues in supportive care. So we have a patient guideline for distress, for immunotherapy side effects, and for nausea and vomiting. We have a patient guideline for lung cancer screening. Should you be screened? What are the pros and cons of it, and so forth. And we have an age-related guideline for adolescents and young adults with cancer. And then, as I mentioned, we have language translations of some, but not all of our guidelines. So this shows one of the print versions of a patient guideline. This, of course, is the cover, and this is for invasive cancer. This is the 2020 version. We try to keep the patient versions as current as we can. We're not able, unfortunately, because of funding issues, to keep the patient guidelines quite as current as the professional ones, but we strive to keep them as current as we possibly can. This shows a typical table of contents for one of the guidelines. Again, this is the invasive breast cancer patient guideline, and we divide the issues or chapters by major category, as you can see. And this shows, for instance, the part of the patient guideline that talks about staging. Again, we try to put it into context. We try to put it into language that the vast majority of adults will be able to understand. This is the same sort of information or same sort of partitioning or flow of information that the professionals would also follow as they go through an individual patient's therapy. There's a section here on testing for breast cancer, and this section again would vary greatly from tumor type to tumor type because there are different tests, especially different biomarkers that are utilized depending upon the specific tumor type. This shows a page in this chapter on hormone receptor tests. So it describes what a hormone receptor is, what kind of hormone receptors there are, how they're measured, and so forth, and also what they're utilized for. There's a section on treatment options, and again, all the major different treatment options that are available are included here. There's a description of what the treatment option is, pros and cons, what it means, and so forth. And this, for instance, is the use of endocrine therapy in the treatment of hormone receptor positive breast cancer. It tells you, again, what the rationale is for using endocrine therapy, what the different types of endocrine therapy are, and typically as well, how they're administered. This then gets into the specifics of how do you actually go about treating, or how would the tumor actually be treated in the individual. So this, if you look at the top, is for patients with stage 1, 2, and 3A disease. Patient already has been educated about what stage means and how that's derived. And as for hormone receptor positive and HER2 negative and node negative disease, Again, those terms have already been dealt with in the booklet, so that the patient can get to the right place in terms of treatment based upon their knowledge base already. And then it specifically states down in Guide 7 what the appropriate treatments are, or treatment options are, based upon the specific stage and other clinical context. And this shows a similar page for hormone receptor negative and HER2 negative disease, again in the adjuvant setting. And it shows, and now you see the preference stratification that we talked about in the professional guideline, the chemotherapy options that are preferred versus those that are useful in some circumstances, or others that could be used, but would not fall into one of the other two categories. Those of you who have gone through cancer treatment know that there are a lot of people that you get to know, and a lot of people that you have contact with through the course of your treatment journey. And so one of the sections we have is, who's the treatment team? You know, what are the different specialists, different types of people that you're going to meet as part of your treatment team, and what do they do? What's their role in the team? So you can see your primary care doctor should definitely be involved, and is the top person listed in this long list. There's a pathologist, a diagnostic radiologist, surgical oncologist, medical oncologist, palliative care specialist, advanced practice providers, oncology nurses, nutritionists, psychologists, and psychiatrists. And then there are others that are likely to be involved, but maybe not. Anesthesiologists, interventional radiologists, radiation oncologists, and so forth. So this is really a way to help educate patients and their families about, 12 different people came into my room today, or I have 4 different appointments to see different specialists, and I don't understand why I'm seeing so many different people. This is a way to really help educate people in terms of why there are so many people involved in the cancer care team. And then we have a section on, for this specific disease, what are the major questions that you should be asking? And it's not that each patient needs to ask each of these questions, but it gives patients an idea about the types of questions that they should feel free to ask their healthcare provider. And as you can see at the bottom, there's blanks for people to write in additional questions, because everybody has different questions and all of them are important. And so we want to be sure that patients' individual important questions also get addressed. And we do encourage patients to write their questions down and bring in written materials with the questions and so forth, because, and I've experienced this, some patients come in and they have a whole series of questions and we sit down to talk about them and they can't remember them. That's why having them written down in a piece of paper is so helpful and empowering to patients, and quite frankly facilitates the entire interaction from both the professional and the patient perspective. The booklets also have a glossary in terms of what are some of the words that you're going to be hearing that you may not understand or may not be in your typical vocabulary, because they're not used typically. So, what's a boost? What's a bilateral oophorectomy? Those sorts of issues these are terms that are commonly used in the treatment of cancer in the clinics, that are not things that most patients would know. So we want to be sure that they have the sort of information that they need in order to understand the language that people around them are going to be speaking. And then again, transparency. NCCN always wants you to know who has developed the information that you're using. The people listed at the top are people who take the professional guidelines and then translate them into understandable English. And the people on the bottom are the people who are members of the NCCN breast cancer treatment panel. Again, if you were in the breast cancer space professionally, this is a really impressive list of experts specifically related to breast cancer. You also will see on the far right, the 4th name down, Mary Lou Smith. Mary Lou Smith is a patient advocate, and the vast majority of our NCCN panels, even the professional panels, include at least one patient advocate as a full participant, voice and vote on the panel. And their role is really key and so important in the guideline development process. So what we have now is, you can see on the left, we have the NCCN. We have our 30 member institutions, really stellar institutions that have the faculty, that have the expertise that they then devote and share with us to develop the NCCN clinical practice guidelines in oncology, the professional versions. And then we move off to the right, where we take that professional version and then translate it into a guideline for patients that, again, provides important information, easy to learn format that can be used by patients, their families, and others that support them. So we think that the guidelines for patients really empower families. It puts the patients and the providers on the same page with the same information. So if you have a practitioner or provider that is utilizing the NCCN guidelines, and most do in the United States, the practitioner's mental model of the flow through the different issues and the decisions that need to be made is the same as is in the patient guideline. And so it really harmonizes, if you will, the decision-making process between the providers and the patient and their families. It also helps to assure patients, no matter where they're treated, that their treatment is consistent with what the experts agree is the standard of care in the United States. So if this treatment is different than is what is in the patient guideline, the patient should ask. They should figure out, you know, I'm not being treated according to the NCCN guidelines. Why not? Not everybody is appropriate for treatment according to our guidelines, and so it doesn't mean that the wrong decision is being made, but it may be. It may be. And the patient should have the privilege of knowing if their provider is deviating from what is widely acknowledged standard of care. Why is that happening? It also helps. They also help to ensure that patients are aware of all of their treatment and care choices, that there isn't bias to the provider in terms of the treatment that's actually being offered, and it allows patients to really self-advocate for their own best care because it gives them a third-party, trusted, respected reference that they can use and say, it says here this, you know, why is that not happening for me? So the patient guidelines are available in 3 different formats. They're available online, they're available through a mobile app, and they're available through printed versions. The online versions are found at our website. If you go to nccn.org/patients, it will get you to this landing page where you can then scroll down, and all of the different patient guidelines are available, are displayed there. And you can select whichever one you want. You can view it online, or you can download it in PDF format to your own computer or to print out on your own printer. We have the app that is available both for the Apple, the iOS, as well as the Android operating systems. And again, you can go to the app stores and download the guidelines for patients onto your cell phone. You don't have to download all of them. You can pick and choose which ones you actually download. But this means that this sort of information is always available to you, no matter where you are. And then finally, print versions are available via Amazon. And as you can see here, if you're an Amazon Prime member, the booklets get shipped by Amazon Prime, and you search for these books exactly as you would any other book within Amazon. As you can see, there is a charge here. That's not our fault. Amazon will not let us give these away for free on their website. They require that we charge for them. And so we charge as low a fee as we can, according to Amazon's policies, to actually make this happen. It's really kind of neat what actually happens here. If you click on a book and put it in your shopping cart and then buy it, they don't go and pull a copy off the shelf. What that really does is it sends a message to a printer to print a new updated version of the guideline on demand. And that's so important to us because it means that when you go there, if you're purchasing a new book, you have to be careful because sometimes people sell these secondarily and they're out of date versions. But if it's a version that is our most recent version, and you print it, you click on it and buy it, it prints the most recent version. So if there's an update to a patient version, all we have to do is go in and change the file in Amazon, and the very next copy that's purchased is the new updated version. We do have translated versions of our guideline in Japanese on the left, for those of you that don't speak Japanese, and Russian on the right. We translate as many of these booklets as we have funding to translate. And as you can see on the one on the left, the stomach patient guideline, in the middle banner on that title page, you can see that there are different foundations, No Stomach for Cancer, the Stomach Cancer, and Deborah's Dream Foundation. Those are patient advocacy groups who have helped to financially sponsor the development of this guideline. And inside, if you went inside, you would find a long list of advocacy organizations who have endorsed our patient guidelines. So we work with literally over 100 patient advocacy organizations to help develop these booklets, and they also help distribute them. And some of the organizations actually help to finance them. So we also have webinars that we give through our continuing education program, and some of these webinars are focused specifically on patients and their families, and some of them are listed here. We have live webinars as well as recordings of those live webinars. So if you go to our website and under patient resources, you'll find that there are recorded webinars for different diseases that you can go and listen to. And we call it Know What Your Doctor Knows. There are providers that give presentations about the specific disease that we hope are an understandable, and they are, understandable language for patients and families. And we specifically have 2 live webinars coming up soon on metastatic breast cancer as part of the Know What Your Doctors Know series. One on Thursday, October 8th, and one on Monday, October 12th. Again, you can register and get to those very quickly. So NCCN Guidelines, patient guidelines, the most widely utilized guidelines in cancer care. They cover the continuum of care. They're updated continuously. They're transparent. They have multiple uses. Use of them improves outcomes of cancer care. It also decreases costs of care. And patient versions are available to empower patients and their families. Thank you. So with that, I think we have time for some questions.
Yeah, so if anybody has questions, please put them in the chat box and I will read them off to Dr. Carlson. So we did have a question come in. Are there any guidelines for those of us currently experiencing NED with no maintenance? And a second part of that question is, how do you then become a patient advocate with NCCN?
So NED means no evidence of disease. First of all, that's a very good abbreviation. I love to see that abbreviation. And that really would fall into what we call surveillance and survivorship within the oncology treatment spectrum. So surveillance really relates to follow-up of the individual to detect early recurrence or major complications of treatment so that they can be intervened. The surveillance part of the guidelines actually is in the disease-oriented guidelines, and it following diagnosis, treatment, and then there's the surveillance part that will be a section of the guideline that talks about, so what's appropriate follow-up of this individual who has no evidence of persistent disease to be sure that they stay that way, and if they have recurrence of disease, that it's detected so that it can be appropriately treated at the time that the recurrence is detected. So yes, each of our disease-oriented guidelines has that section. And how do you become a patient advocate with NCCN? I wish I had a nickel for every time I was asked that question. The patient advocates are typically individuals who are nominated by someone on one of our panels. So they tend not to be nominated by advocacy organizations or self-nominated, although some people do specifically self-nominate. You know, the sort of individual that we're looking for is pretty special, and that's the same for our experts. So the sort of person we're looking for an advocate is that they need to be they need to understand the disease from either the patient or the caregiver, the sort of family caregiver, non-professional caregiver perspective. They need to understand that on the panel, they're not representing themselves, they're representing a broader constituency of patients that would be appropriate for that specific guideline. They have to be people who understand the scientific process so that they can understand the discussions that are happening at the panel meetings. They have to be articulate. They have to be able to convey their perspective efficiently and in an understandable way. They have to do, it's what I call play in the sandbox well. They need to be people who are friendly, respectful, show appropriate body language, aren't intimidating, aren't aggressive. They're the sort of people you'd want to go out to dinner with and have a nice conversation with. And then finally, and it's one of the big issues also, they have to be people who aren't intimidated by doctors. You know, that they should be respectful, but they can't be intimidated. They need to be able to feel the ability to raise their hand and say, "I'm sorry, but what you're saying is bullshit." You know, it's not the way patients think about it. And you know, sometimes those are really important moments within panel meetings when the advocate speaks up in that way. So it's not easy to get on the panels, and typically once an advocate gets on the panel, they never leave. They never leave. We don't have term limits, and you know, Mary Lou Smith, who's on the breast cancer panel, joined the panel I think in 1997, and she's still on the panel. So it's not easy. But they're really special people, and their role is so important. It totally changes the conversation in these panel meetings, and really grounds the discussion, you know, around the patient and the patient experience.
Thank you for that. And you may have, Dr. Carlson, gone over this, but somebody asked for clarification on how people get materials from NCCN, and are they free?
So we have materials that are free for non-commercial use, and then we have materials for which there are licensing fees or access fees. All of the patient guidelines are absolutely free of charge. You just go to our website and you know you can access them. The professional guidelines are also free. You have to register at the website, and the registration is primarily saying that you're not going to use the guidelines for commercial purposes. And then you can access any of the professional guidelines. You can download any of the professional guidelines that you choose to. Our business model is that we charge for people who use our content to make money. So if somebody is using our guidelines for commercial purposes, for instance, if an insurance company is using our content to decide what they're going to pay for or not, that's very valuable to them, and that's a commercial use. And so an insurance company would have to license our content in order to be able to legally use it. But for patients and providers at the point of care, it's all free.
Great, thank you. How often are the guidelines updated?
So each of the guidelines is updated at least once a year. And then again, if there's a new drug approval, if there's a practice change in clinical trial that is reported either at a scientific meeting or published so that it's sort of available for the first time, the panel will meet, and then we'll update the guideline if they agree that the guideline should be changed, that the drug is in advance and should be something that's widely available. So it varies at least once a year. But again, the non-small cell lung cancer guideline is right now, as we speak, going through its 7th update for 2020.
Great. And related to that, you had mentioned that the patient guidelines sometimes lag behind the updated clinical guidelines. On average, how much of a lag time do you think that there is?
So it will vary from site to site. The development of the patient guidelines is not paid for by member institution dues. And that's because the development of the patient guidelines is translation, not development of changes in recommendations. And so the patient guidelines are, as I mentioned, as I would have discussed earlier, sort of outside the firewall, outside the financial firewall. And so we update the guidelines as often as we have funding to do. And the funding comes from multiple different sources. It comes from foundations, it comes from patient advocacy organizations, it comes from just donations from individuals, and it comes from contributions or grants from industry, especially the pharmaceutical industry. And whenever we have adequate funds to update a guideline or to develop a new guideline, because we're continuing to expand the guideline of patient guidelines, we do it. Some disease sites, there's a lot of change, a lot of activity. Lung cancer, colorectal cancer, breast cancer, there's a lot happening. And so we try to update those at least every year or two. For other guidelines, for other diseases where the options are fewer, the guidelines might be updated, patient guidelines might be updated every 3 or 4 years. It varies. We try to get the biggest impact for the fund based upon the funds that we have available.
Great, thank you. Are you able to speak to how breast cancer and tamoxifen impact the possibility of uterine or ovarian cancer?
I can. Tamoxifen does not, to my knowledge, and I'm a breast cancer specialist by training and have done a lot of research looking at tamoxifen. To my knowledge, tamoxifen doesn't impact the risk of ovarian cancer in a meaningful way. It does increase the risk of cancer of the uterus, endometrial cancer, especially in the postmenopausal women. In the premenopausal women, the increase in risk is very, very, very small. It's a increase in risk that I would not think is important to most people. But in the postmenopausal woman, tamoxifen is associated with the development of cancer of the uterus. The numbers vary a little bit depending upon series. It's probably in the range of about a 1% risk, maybe 2% risk in a woman who is anticipated to take tamoxifen for 5 years. The vast majority of those cancers of the uterus are detected because of vaginal spotting, bleeding from the vagina. So any postmenopausal woman who is on tamoxifen who has any vaginal spotting or bleeding should be immediately evaluated for cancer of the uterus. Most bleeding and most spotting in such women is not cancer of the uterus. But pretty much all cancers of the uterus related to tamoxifen cause spotting or bleeding. So ultrasounds of the uterus, routine biopsies of the uterus are not recommended. The only recommendation is beyond routine health maintenance in terms of cervical cancer screening and so forth, is that if a woman on tamoxifen has spotting, it needs to be evaluated promptly. But again, most of the time, that will not be cancer of the uterus.
Thank you. Does any of your data show crossover benefits for other cancers? For example, this individual is on a clinical trial for ovarian, but using a non-small cell lung cancer drug regimen.
Yeah, so if you look at our guidelines, there are probably almost all, not all, but almost all medications that are recommended for one disease type, you will also find recommended for some other disease types. The FDA has recently approved a couple drugs that are they call pan-tumor types, or agnostic to where the tumor arose, where those drugs the FDA thinks can be used across all disease sites that have a specific type of biomarker, specific gene abnormality. NCCN has not been quite so generous. We look at them individually by individual tumor type. But it's very common that a regimen used in one type of cancer is also used in other types of cancer. But it's very unusual that a drug is used across all types of cancers.
Okay, those are the questions that came in so far on our chat. If